right. Well, it's 12:02, so we might as well get going. Thank you everyone for being here today. Welcome. We're super excited to have all of you here today. I want to welcome everyone on behalf of Project Firstline Rhode Island and the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health. And we're in partnership with CDC today. So thank you so much for taking time out of your busy day. We're going to be talking about measles in a healthcare setting today and review some important infection prevention and control strategies. We have offered this in some other sessions over the last few years, but with the World Cup coming and the rise of measles over the last few years, I think any opportunity to review kind of the clinical course and what we can do as healthcare workers is super important and hopefully helpful. So before we begin, in the chat, you'll see Kelly Cotito Rivera. She's one of our Project Firstline Rhode Island nurses, and we have a whole team behind the scenes helping me run this webinar today. Feel free to introduce yourselves in the chat if you'd like. I imagine most of you are coming from Thunder Mist, which is great. We're super excited to have you here. I do recognize a few names in the chat today. For those of you I don't know, my name is Alexis Kearney. I am a practicing emergency medicine physician here in Rhode Island, and I serve as the consultant medical director for Project Firstline Rhode Island. My background is in epidemiology and microbial diseases and have responded to outbreaks around the world in the US, Asia, and Africa. And I'm super excited to be here with all of you today. So if you've been here before, welcome back. If it's your first time at one of our webinars, welcome. Just a few reminders before we jump in. Everyone is muted. At the bottom of your screen, you'll see a Q&A box. You can use this for questions. Provided we have some time at the end, we'll have a brief Q&A session and try to get through all of your questions. If we happen to run out of time, because there is a lot of material in this, please leave your email and we're happy to follow up with you after the fact. The chat box is also available if you have any questions or want to connect with us, and we'll be monitoring that as we go. So one last call for the pre-session survey that is in the chat box here. Kelly, if you want to throw it in one last time. There are a few requirements to getting CNE credit. It's approved for 1 contact hour by the Northeast Multi-State Division Education Unit, which is an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. To receive your CNE, there are 4 steps that are required. So first is completing that pre-session survey, which is in the chat right now. So please go ahead and fill that out if you haven't. That survey does close once we get into the material in this presentation. Step 2, of course, is the live training, and you are here, so you've completed that so far. And then step 3, there is a post-session survey that will be emailed to you tomorrow. And then finally, there is a post-session quiz, and that will also be emailed to you tomorrow. For other healthcare colleagues that are not needing CNE, so if you just need a certificate of training or EMS continuing education or dental IPC continuing education, it's just steps 1 through 3. Step 4, which is the post-session quiz, is optional. So why are we talking about measles? Measles was once considered to be eliminated from the United States, but unfortunately we've seen a sharp increase over the last few years. Overall, there's been a decrease in measles vaccination nationally, which puts people at increased risk of contracting the virus. About 2 years ago, a little over 2 years ago, the CDC issued a Health Alert Network health advisory, which is basically an email notification that goes out to clinicians and public health officials regarding the increase in global and US measles cases and to provide some guidance on it. As many of you know, hopefully all of you know, measles is not just a rash. It is an acute viral respiratory illness, and it is incredibly contagious. It spreads easily and can be serious and even fatal, particularly for small children. Outbreaks of measles in healthcare settings do occur, and transmission to and from healthcare professionals continues to be reported. Healthcare professionals are considered to be at higher risk of contracting measles than the general population due to the fact that people with measles are more likely to seek medical care due to the severity of their symptoms and being unsure as to what's going on. Measles is highly contagious and potentially under-recognized. We're going to talk a bit about that today, which ultimately leads to delays in patient isolation and diagnosis. So today we're really going to talk about measles in and of itself, kind of review the clinical criteria, and then the infection prevention and control actions that all of us can take in our healthcare roles. So our agenda for today, we've already done our welcome and introductions. Next, we're going to talk about the learning objectives. We'll discuss the history of measles and provide a quick clinical overview. And then in the second half of the webinar, we'll discuss vaccine recommendations, infection prevention and control actions, and then talk about a few case scenarios before going over our key takeaways and final announcements. So our learning objectives for today, we have 5 of them. First is to understand what measles is and learn about its resurgence in the United States. Second, learn how to rapidly recognize measles based on history and clinical presentation. Third, understand how measles spreads. 4, know the steps to take if there's an exposure with and without proof of immunity. And then 5, learn the infection prevention and control actions to help decrease the spread of measles. So first, we're going to review a brief history of measles in the US and then discuss its current state. So before the live measles vaccine was licensed in 1963, there were somewhere between 3 and 4 million people who were infected with measles annually in the US. Most of these, unfortunately, though, were not reported to health officials. Historically, measles was a childhood illness, and most people contracted it by the time they were 15. Despite it being a nationally reportable disease since 1912, around 550,000 measles cases were reported annually. Of these, approximately 48,000 individuals required hospitalization, 1,000 developed acute encephalitis, and somewhere between 400 and 500 people died annually. In 1968, an improved live measles vaccine was licensed, and then in 1971, the MMR vaccine was introduced. So this is the measles, mumps, and rubella vaccine, and it provides protection against all 3 illnesses. In 1989, the US and other countries around the world saw an increase in cases due to low vaccination rates. This was due to vaccine hesitancy, which was linked to widespread misinformation about the safety of the vaccine. And then in 2000, or leading up to 2000, there was a lot of work being done around public health to increase vaccine uptake, and measles was ultimately declared eliminated in 2000 in the US. So we'll talk a little bit more about what elimination actually means on the next slide. So since 2000, the annual number of cases has ranged from a low of about 37 in 2004 to over 2,000 last year in 2025. And the majority of the cases that we've been seeing in the United States have been among individuals who are not vaccinated against measles. And many, at least until recently, were linked in some way to imported cases. So visitors to the United States that were coming here or people from the US that were traveling to other places and then came back with it. Since measles is so contagious, it quickly and easily spreads in communities with large groups of unvaccinated people. And over the last year or 2, really, we've seen a significant increase in measles cases across the country, which has led epidemiologists and departments of health to really worry about sustained measles transmission within the US. So the World Health Organization defines measles elimination as the absence of endemic measles virus transmission in a defined geographical area for at least 12 months or longer in the presence of a well-performing surveillance system. So like we talked about, measles was declared eliminated in the US in 2000, meaning that there was no measles virus spreading within the country and that new cases were only found when someone contracts measles abroad and then returns here. And this was really a tribute to the widespread vaccination campaigns that were performed both here and around the world. However, travelers continue to bring measles into the US, and it can sometimes spread and cause outbreaks, particularly among people who are not vaccinated. So while the term elimination does not mean gone forever, the rapid rise and increase of cases over the last 2 years does pose a threat to the US losing its elimination status. So why are we talking about measles now? Why is it a concern? Well, one, we've seen a decrease in measles vaccination rates globally, which has resulted in an increased risk of larger measles outbreaks worldwide, including in the United States. So let's take a step back and define what an outbreak is. It's when a disease occurs in greater numbers than expected in a particular area. So as we know, measles outbreaks have been increasing worldwide, mostly spreading amongst those who are not vaccinated. And as we talked about, measles is typically brought into the US by a traveler who contracted the virus while in another country. It then enters into communities of people who are largely unvaccinated, and the outbreak starts to spread. And outbreaks in countries where Americans travel to frequently can directly contribute to an increased rate of measles outbreaks here. So in recent years, measles cases have been linked to travelers from frequently visited countries, including the Philippines, Ukraine, Israel, Thailand, Vietnam, England, France, Germany, and India, places that have also had rather large outbreaks. So this is, I pulled some data from the CDC website earlier today. So these next few slides are as of May 21st. So this slide is showing the total number of measles cases reported by year in the US. And this is as of May 21st. So far this year, we have seen almost 2,000 cases, confirmed measles cases here in the United States, so 1,952. And they were reported over 40 jurisdictions. Only 9 of those cases actually have been reported among international visitors who are coming to the United States. There have been 29 new outbreaks, defined as 3 or more related cases, reported in 2026, and 93% of confirmed cases are outbreak associated. For comparison, there were a total of 2,288 confirmed measles cases last year in 2025, and a total number of 48 outbreaks. This year, about 21% of cases have occurred in individuals less than 5 years of age, about 51 in the 5 to 19 years old age group, and then 28% 20 years and older. The vast majority, 92%, were among individuals who are unvaccinated or with unknown vaccination. We've seen 6% of cases requiring hospitalization, and thankfully 0 deaths so far. So this is a graph showing weekly cases by rash onset date. So you'll see that we had a pretty big spike in kind of the December-January time period, but we're still seeing cases. And of course, the concern is that we may see more of this as travelers come in preparation for the World Cup in a few weeks. And then this is a map showing the jurisdictions that have been affected, who have reported measles cases since the onset, since the beginning of the year, excuse me. The darker the blue represents more cases reported in that area. So we've got our first poll question. So I encourage some audience participation. So measles cases have increased globally due to A, decreased supply of vaccine, B, decreased vaccination rates, C, decreased efficacy of the MMR vaccine, or D, none of the above. We'll give everyone a minute to reply, pick their best answer. And Kelly did share the link for the CDC measles data in the chat as well. All right, it looks like we got majority of people responding to the survey so far. And everyone selected B, decreased vaccination rates. Excellent. Perfect. All right, so we're going to review the clinical characteristics of measles. So timeline is an essential piece of information to collect when you are thinking about measles. So after exposure to the measles virus, there's an incubation period of somewhere between 10 and 14 days, during which the exposed person is asymptomatic. Around 2 to 4 days prior to the onset of the rash, the prodromal symptoms begin. So this includes fever and at least one of the 3 C's, which we're going to talk about on the next slide, which is cough, coryza, or conjunctivitis. So following these prodromal symptoms, the rash begins. The date of rash onset is considered day 0 when talking about measles. So on average, the time from exposure to the onset of rash is 14 days. And the longest period that it can happen is 21 days. People who develop measles are considered contagious from 4 days before to 4 days after the rash. So this information is super important in terms of figuring out isolation and exclusion policies for those who develop measles. So as we'll talk about a bit later, getting that really specific history when you're evaluating a patient and you're concerned about measles is incredibly important. The challenging part of measles control is that people are infectious before the rash and can be infectious when they have really nonspecific symptoms that look like other respiratory illnesses. So these are the 3 C's that we talked about: cough, coryza, and conjunctivitis. Coryza being a runny nose, and conjunctivitis is that red, watery eyes. Other symptoms of measles include fever, which can be quite high, a maculopapular rash, which you'll see on both of these kids here, and then white dots inside the mouth, which are called Koplik spots. So these are characterized as clustered white lesions that appear inside the mouth, and they typically appear 2 to 3 days after symptoms begin. They're sometimes described as grains of salt on a reddish background, and they occur prior to the skin rash. I feel like rashes are always really challenging. I'm right there with you. This particular rash for measles starts on the face, at the hairline or behind the ears, and it spreads downwards to the neck, trunk, and extremities. It's maculopapular, so small raised or flat red bumps. These spots may coalesce or become conjoined as the rash spreads, and it's not itchy, so it fades in the same order in which it appears. All right, which brings up poll question number 2. What is the typical presentation of measles rash? Starts at the trunk and then spreads to the hairline and extremities. Starts at the extremities and spreads everywhere, including palms and soles. Starts at the hairline or face and then moves down to the trunk and extremities, or the rash follows no pattern. Awesome. So almost everyone got it. The answer was C, starts at the hairline or face and then moves down to the trunk and extremities. So that pattern is super important when we're talking and evaluating our patients here. All right, so complications. There are a number of complications that can occur with measles. Most common are diarrhea, otitis media, or a middle ear infection, and pneumonia. These complications can cause substantial morbidity, in particular measles pneumonia, which can cause severe illness in infants and immunocompromised people. More severe complications, such as requiring hospitalization, which occurs in about 1 in 4 cases, and then even more severe things like encephalitis and death. All of these complications are more common in 2 age groups, those under the age of 5 and those over the age of 20. Complications are more common amongst individuals not vaccination against measles. I did want to highlight one final complication, which is listed in the table, which is a delayed complication, meaning that it happens after recovery from the virus. Subacute sclerosing panencephalitis, or SSPE. This is very, very rare. It occurs in somewhere between 7 to 11 per 100,000 cases. But it's a truly devastating neurologic complication that occurs about 7 years after measles infection. And it's more common in those who develop measles at less than 2 years of age. And it's essentially a progressive neurologic decline, which generally leads to death within about 3 years of onset. So this is typically something that very young children get that presents many years later and ultimately results in death. Hey, Ali, there was a quick question in the chat about some people having difficulty connecting. If you might be able to follow up on that, that would be great. So just transitioning towards treatment. There is no specific antiviral therapy for measles. Really, it's supportive care to help relieve symptoms and address complications that may arise from measles infection. Severe cases for children that are hospitalized can be treated with vitamin A. We're typically giving 2 doses when the diagnosis is made and then repeated the next day. And a third dose can be considered if the individual has a vitamin A deficiency. But while there's no specific treatment, post-exposure prophylaxis is an option, so PEP. And this can be given within a specific window and may provide measles protection or shorten the course or severity of symptoms. So people exposed to measles who cannot readily show that they have evidence of immunity against measles should and can be offered post-exposure prophylaxis. So we have 2 options. One would be to administer the MMR vaccine within 72 hours of initial measles exposure. And then there's another option for administering immunoglobulin within 6 days of exposure. We still need to monitor these individuals even after they've received post-exposure prophylaxis for the entire incubation period. So who's at risk for measles? Individuals who have traveled internationally for within the last 21 days. And while this has historically been true, as we've seen over the last 2 years, we're really seeing a lot more local transmission. So many cases will not have a travel history. Individuals who are not vaccinated or who are under-vaccinated. Under-vaccinated means that they have not received both doses of the vaccine. They've only received one. And this may be for a variety of reasons. One, maybe they are in the process of completing their vaccination and received their first dose but haven't yet received the second. Or maybe they got the first dose and then decided not to go ahead and complete the course. Both of those would be considered under-vaccinated. Individuals who are immunocompromised with a weakened immune system, infants and children, particularly those less than 1 year old, and pregnant individuals. So how does measles spread? We know that it's a very contagious respiratory illness. The virus lives in the nose and throat of infected individuals, and its primary mode of transmission is by breathing in droplets when someone infectious coughs, talks, or sneezes. The virus can also spread by direct contact with infectious droplets that enter the air by coughing or sneezing, and then those droplets land on surfaces. Another individual comes along, touches that contaminated surface, and then subsequently rubs their eyes, nose, or mouth, and then they can become infected themselves. One of the challenging aspects of measles is that it can remain in the air for upwards of 2 hours. And because of that, one infected or contagious individual can spread it to many others as well. So this graphic really just tries to depict how contagious measles is. And so, we know that each individual who's infected with measles can infect upwards of 12 to 18 people. So making it way more contagious than influenza or even things like Ebola. There is some variability, of course, in these numbers, and that'll really be impacted by the environment, crowding, particular strains of the virus. But really, it's important to remember that these numbers can be significantly reduced by strong vaccination campaigns and other infection prevention and control strategies. So we'll review our vaccine recommendations. So the MMR vaccine is very effective in protecting people against measles, mumps, and rubella. 1 dose of the vaccine provides around 93% protection against measles, and 2 doses bumps that up to 97% effective. So typically, this is going to be something that our pediatric patient population is receiving, the first dose being given around 12 to 15 months of age, and then the second dose between 4 and 6 years old. Adults without evidence of immunity should get at least 1 dose of the MMR vaccine, but certain adults may need 2. And those include adults who are going to be in settings that pose increased risk for measles or mumps transmission. And we should really make sure that they have 2 doses separated by 28 days. So these adults include students at post-high school education institutions. So those going off to college or university, healthcare professionals, so all of us on the webinar today, and then international travelers. There are some contraindications to receiving the MMR vaccine, so individuals who are immunocompromised should discuss that with their doctors. Individuals who have a history of allergic reaction to the MMR vaccine, which makes sense, and those who are pregnant. So here is another poll question. A person is more protected from getting the measles vaccine when they receive 2 doses of the MMR. Awesome. So we had everyone got that question correct. The answer is true. All righty. So now we're going to get into the meat of the infection prevention and control actions that healthcare professionals can take if a measles case is suspected. Okay, so we're going to go through 7 specific recommendations. Okay, so the first one is vaccination. So ensuring that all healthcare personnel are vaccinated against measles is incredibly, incredibly important. So there is a group of individuals that are going to be presumed immune to measles. So these are individuals who were born prior to 1957, those who have written documentation of vaccination with 2 doses, those who have laboratory evidence of immunity or lab-confirmed disease. That final bullet, so birth before 1957, that's because before 1957, so before the vaccines were available, nearly everyone was infected with measles, mumps, and rubella viruses during their childhood. And so the majority of these individuals were likely infected naturally and presumed infectious. But if you are a healthcare professional born before 1957 and you don't have evidence of immunity to measles, you should really consider getting the 2 doses of the MMR vaccine, and your employer may actually require it. Okay, so really trying to minimize potential measles exposure, and I think this slide may be particularly helpful for those of you working in the outpatient world. There's going to be settings where we get phone calls trying to figure out whether or not someone who's calling in for a sick visit may be at increased risk, or maybe you have someone in your clinic and you're trying to figure out what to do with them. So let's start on the left side of the screen. So in the blue box labeled before arrival to the healthcare setting, expected. So this is when the healthcare professional has a heads up that the patient is coming in. So someone may call to report symptoms that are suspicious for measles, and it'll be really helpful to triage the patient over the phone, which I'm sure you already have a system for this, and to screen for symptoms. So gathering as much information about the timeline of the symptoms is really, really important. And then giving them good guidance as to what they should do. So giving them instructions for arrival to your healthcare office, telling them to avoid public transportation, recommending that they wear masks on their way to the facility, and really trying to minimize the number of people that are accompanying them, if at all possible. Include instructions as to which entrance to use and what precautions to take, and really try to give them the ability to anticipate what's going to happen when they come. So letting them know that they'll be placed in a mask when they arrive, that they'll be placed in an isolated or a private room for evaluation and testing, and then making sure that our healthcare professionals have their own PPE on and ready to go. So your N95 and other PPE. Of course, it's a bit more challenging if we don't know that the patient is coming in, if we don't have that heads up. So that's where the yellow boxes on the right side of your screen come into play. So really utilizing our existing triage stations for rapid identification and isolation of patients with measles, asking about their symptoms and timeline, providing face masks for patients to wear, ensuring that our healthcare professionals have their N95 and additional PPE like gowns and eye protection available, isolating patients as quickly as possible, and then really facilitating adherence to things like respiratory hygiene, cough etiquette, hand hygiene, and your institutional triage procedures. Visual alerts can be super helpful in appropriate languages based on your patient population to remind them about the precautions that are being implemented and why we're doing them. And then really giving additional information to patients that you are concerned about having measles about infection control expectations. So wearing masks, washing our hands, all that kind of stuff. If the patient requires transfer to a higher level of care, such as maybe they need to be transferred to the hospital, it'll be really important to notify the ambulance or any potential transport team that's coming, as well as the receiving facility, so that everyone makes sure that they have the appropriate PPE and that they are ready for the patient, so that they can go appropriately to an isolation room on arrival. So for measles, we are going to use both standard precautions as well as airborne precautions. So standard precautions include your hand hygiene, appropriate PPE, your N95, respiratory hygiene, and then placing individuals ideally into an airborne infection isolation room. So these were formerly called negative pressure isolation rooms. But it's basically a specific type of room that's designed to prevent airborne microorganisms that are in the room from entering into the hallways and corridors. It's a single occupancy patient care room used to isolate persons. And it requires specific kind of cleaning and disinfection. So whoever's going to be turning over the rooms needs to know that there was a patient potentially with an airborne illness in the room. And making sure that we're following appropriate protocols for that. Using signage to remind individuals of their standard precautions as well as airborne precautions, available N95s or other respiratory masks, and keeping the door closed at all times is incredibly important. So patient placement, we mentioned it briefly already, but placing patients in your airborne isolation rooms as quickly as possible is really important. But if you don't have one, getting them into a private room will be essential. So we'll want to put them in a private room. We'll want to make sure that they are masked and that they have the door closed. If you have a HEPA filtration system, that can be turned on and that can be helpful. And then they need to keep that mask on for the duration of time that they are in a private room that is not an airborne infection isolation room. And after the patient leaves that room, if it's not an airborne isolation room, we're going to leave that room vacant for about 2 hours. And that's to allow for any potential airborne contaminants to settle, and then it can be cleaned with our EVS staff. Healthcare professionals without acceptable evidence of measles immunity should not enter the room of a known or suspected patient with measles. So only healthcare providers with proof of immunity should be caring for patients with suspected measles. And all healthcare providers who are interacting with these patients should have respiratory protection on, such as an N95 respirator. If we're transporting patients with known or suspected measles within or between healthcare facilities, really trying to limit that transport as much as possible for really truly essential diagnostic or therapeutic procedures that cannot be performed in the room is going to be important. If we have to transport them within the facility, wearing a face mask, using the shortest transportation route, and really trying to minimize contact with others or people who are not essential to the patient care. Communication is key in this sense, so really notifying the healthcare professionals in the receiving area of the impending arrival of the patient, reminding them to take the necessary precautions, making sure that they have their PPE on. And then, of course, as we talked about, if they need to be transported to a different healthcare facility, letting that facility know so they can prepare an isolation room for that patient on arrival. Patients with measles who have confirmed measles need to remain on airborne precautions for 4 days after the onset of rash. So as we talked about at the beginning, the onset of rash is considered day 0. Immunocompromised patients, though, need to remain on airborne precautions for the duration of illness. This particular with respect to visitor access and movement within the facility may not be particularly applicable to your outpatient clinics, but if there are persons that are trying to come and visit this individual, we're going to need to make sure that they are also vaccinated and really try to limit the number of different people that are coming to visit to those who are really necessary for the patient's well-being and care. And that's really because we want to limit the potential for spread. We're going to have them all masked and implement those other strategies, but really trying to limit the potential will be important. And then, of course, cleaning and environmental infection control. So really relying on our EVS staff to use the appropriate disinfectants, to clean and disinfect frequently touched surfaces or objects, using our EPA registered disinfectants, and then managing used and disposed PPE and other patient care items will be really important as well. So we really want to prevent measles exposure, but it may happen. So let's first define what an exposure is. So an exposure to measles in a healthcare setting is considered when spending any time unprotected, so not wearing a mask, in a shared space with an infectious patient with measles who's there at the same time, or in a shared airspace that was vacated by an infectious individual with measles within the prior 2 hours. So if you have an individual who's exposed to measles, you want to determine their measles immunity status. So this is kind of the first step. If they have immunity to measles, so you would implement daily monitoring for signs and symptoms of measles from day 5 after exposure through the 21st day after the last exposure. And provided they have that immunity, they do not need any post-exposure prophylaxis, and there are no work restrictions, so they can continue to work. For asymptomatic people without immunity, those healthcare professionals do need to be excluded from work. They should be offered and ideally administered post-exposure prophylaxis, and they too need to be monitored for signs and symptoms of measles. Patients who are exposed to measles who do not have evidence of immunity need to be placed on airborne precautions for 21 days after their last exposure or until discharge from the healthcare facility if earlier. We want to offer and ideally administer post-exposure prophylaxis and then notify any potential health authorities, so the Department of Health in this case, about other patients that may have been exposed to measles who are being discharged from the healthcare facility so that appropriate follow-up can happen. So if there is a potential measles outbreak, we'll be relying on our infection control professionals to really determine appropriate patient placement within a healthcare facility. Again, this is going to be much more applicable to an inpatient or a long-term care facility. And depending on the size of the outbreak, we may need to be a bit creative in terms of patient placement, finding alternative rooms that don't meet kind of the standard engineering requirements for airborne infection isolation rooms. We may need to cohort patients or physically place patients with confirmed measles in separate areas of healthcare facilities to really try to cohort them. So providing healthcare professionals with job-specific education and training, including things like today's training, can be really important in preventing transmission of measles. Our favorite activity for all of us, I'm sure, is our annual fit testing to make sure that those N95s or other respiratory masks are fitting us well. And we want to make sure that we are redoing that fit test on a regular basis as different masks will fit differently, or any potential change in weight or face shape or shaving a beard or things like that are going to really impact how those masks fit us. So we want to make sure that all of our healthcare professionals are educated and trained and can demonstrate competency in using the PPE that's going to keep them safe. So finally, how we're reporting to public health authorities. This is also a really important step. So making sure that you have clear policies and procedures to alert key facility staff and local authorities so that we can coordinate our response on a statewide level, communicate with your public health authorities so that we can do contact tracing, as well as disseminating information to the public. And in a few more slides, we'll go over some really great local resources that we have through the Department of Health. So to summarize the 7 steps that we talked about, or the 7 actions that we reviewed, they really fall under 3 main categories. So identifying, rapidly assessing symptoms, getting a good history, any potential exposures or known contact with individuals who are found to have measles. We want to isolate those patients, so placing masks on the patient, ideally placing them in an airborne isolation room or at the very least a private room, and ensuring that our healthcare professionals have their appropriate PPE, including N95s, and then informing our local and state health departments and other healthcare leaders about the potential measles case or the confirmed measles case. So what kinds of resources do we have here? And we'll take a few minutes to go over this. So measles is an immediately reportable condition to the Department of Health here in Rhode Island. So if you have a patient that you are concerned may have measles, please call us. A phone number you'll see on the screen, the 222-2577, that is the number during business hours. There is also an after hours phone number. And the link for this nifty little handout is going to be in the chat. Kelly will put it there in a second, and it has both phone numbers on it. So if you are concerned about measles, please call us. It is really, really important to gather as much information about the patient when you first evaluate them. So things that we want to know: what is the timeline? What is the onset of their symptoms? Any potential exposures, their medical history, vaccination status, where they've been traveling to. All of those things are incredibly important, and really trying to get that information the first time that you're in the room with the patient so that you don't have to keep going in and out as much as possible. So these phone numbers will connect you to one of our nurses at CADE, which is the Center for Acute Infectious Disease Epidemiology, and they will walk through with you trying to figure out whether or not this is that we really need to be concerned about measles. And if we are, what we're going to do. So what are the next steps in terms of specimen collection and testing? What recommendations are we going to give to the patient regarding isolation as well as their family members? Education, we're going to ask for information to help with contact tracing and potential workplace exposures if any of that happened. The nurses in CADE are a really wonderful resource in that sense. I think it's also super helpful to figure out the best way for nurses at CADE to get a hold of you. So if you're calling us, consider giving them your cell phone number to make it easy for you guys to stay in touch and keep those lines of communication open, or a phone number to the desk that you're sitting at, or things like that. We want to be able to get back in touch with you to give you that guidance as quickly as possible. And I know when I've called them from the emergency department about cases, I will often give them my cell phone because I might be in one of 20 different rooms at any given time, and that just makes it a little bit easier. But we really want to support all of our clinicians and healthcare providers in the state as much as possible. So take the numbers down and save them in your phone so you have them if you need them. All right, we've got a few poll questions left. So if someone is suspected of having measles, should you isolate that person promptly? Hopefully, this is an easy one for all of you. Perfect. Great. So yes, we want to isolate them as quickly as possible. Next poll question. What precautions should be used when caring for a patient with measles? Standard and enhanced barrier precautions, standard and droplet precautions, standard and airborne precautions, or standard precautions only? Okay, so the answer for this one is standard and airborne precautions. Those enhanced barrier precautions in option A, that's something for our long-term care facilities. So for measles, remember standard and airborne precautions. Okay, so before we wrap up, we're just going to go through two quick case scenarios, and feel free to put some answers in the chat box as we go through these. I invite all of you to participate. So case number one, you have a 23-year-old male who arrives in this particular case to the emergency department, although it could be Thunder Miss Health Clinic, with complaints of fever, cough, and watery eyes that started at the end of his college spring break. The healthcare professional noted small raised spots on the patient's hairline. So what are some immediate questions that the physician should ask the patient? Great, I'm seeing some comments in the chat box, vaccination status, date of symptom onset. And with that, getting super specific, right, about the potential rash, when that started. Travel, great. International travel, immunity, timeline, perfect. Yeah, and maybe asking specifically if he knows that he was in contact with anyone that had measles or was sick, right? Exposure is great. Yeah. And then what are some infection control actions that the healthcare professional should take as they're meeting this patient? Putting a mask on a patient, great. Bringing them to an airborne precautions room, wearing an N95, excellent. Proper PPE, super, super important. And I know it's easy to get, lax with our PPE. Yep, notifying your infection control. Great. So, and if you're in a clinic that doesn't have an airborne isolation room, putting them in a private room and keeping that door closed. Making sure that, I would also make sure that whatever healthcare professional is going to be caring for that patient knows that they have proof of immunity to measles, so knows that they're vaccinated and that it's up to date. Super, super important. Great. Okay, case number two. A mother calls the pediatrician's office to report that her 3-year-old daughter has a fever of 105, accompanied by a cough and a runny nose. She reports that her daughter's symptoms started a few days after they returned from Disney. So, what are some telephone triage questions that we can ask the mother? Immunity status. Thanks, Sharon. Any eye symptoms? So, red, watery eyes. Great. How long she's had the fever, vaccination status, any medications, right? So, vaccine status, known exposures, excellent. The 3 Cs, right? Our cough, coryza, conjunctivitis. There's a rash. So, Disney is really a melting pot. People come from all over the world, and you are standing very close to them for long periods of time, waiting to get on those rides. So, a lot, at least, number of years ago, prior to our current spikes in measles outbreaks, often we would see little blips of measles outbreaks every year related to travel to Disney, simply because of travelers. And then what pre-arrival instructions should the healthcare professional give to the mom? So I encourage you to think about your own healthcare facility. So what are you going to tell people to do when they're coming to see you to get evaluated in person? how does that work at your specific facility? And how can it be improved? So masking, excellent. Yeah, so this is when I really think about, recommending, since this is a 3-year-old patient, right? Her mom's going to be coming with her for any evaluation. So both individuals need to be wearing a mask when they arrive at the facility. Ideally, using a private car, possible, and avoiding public transportation. Ideally, not coming with a whole group unless those other individuals are symptomatic and need evaluation as well. What door are they going to use when they come to your facility? Do you have a separate door where you could kind of have these individuals come in? I know when during kind of the height of COVID, my pediatrician's office had a separate entrance for anyone who's being evaluated for a possible sick visit. Some places are still doing that or have a different area where they see sick visits. And giving them the expectation that they're going to need to wear the mask while they're there. And So it looks like you guys do have a isolation negative pressure room. Excellent. So that's super helpful, right? Knowing that you can hopefully put the patient and their family member directly into that room when they get there. And really giving them that information ahead of time so that they know what to expect. Great. Thank you guys. All right. So we covered a lot of information here today. These are the 5 key takeaways that I hope you remember. Measles is highly contagious, febrile illness that can cause super serious complications and may result in death. Really identifying measles early is critical to preventing its spread. And we can do so much by encouraging our patients to get vaccinated. Remembering that suspected cases of measles should be masked and isolated while they're awaiting their medical evaluation, and that healthcare professionals should follow standard and airborne precautions when caring for individuals with known or suspected measles. Just a few last things before we sign off today. These are some really helpful handouts that show the skin findings and rashes for measles. We'll put the links in the chat as well. These are some posters that can be helpful to download and print or hang in your facility. There's some key points on the right side of your screen summarizing measles, and those can be really helpful for your staff. Some information just how to reach us at Project Firstline Rhode Island, our contact information. We have one more session coming up. It's scheduled for Monday. There is a small chance it may be rescheduled, but we will notify everyone via email. We'll be having the continuing education and CNE for this session, and you can pre-register on our website as well. Here's our references for today. And then I just wanted to go over those requirements real quick again for getting the CNE. So for getting your certificate of training, you've attended the webinar. Tomorrow, the post-session survey and quiz will be sent out, and you'll have until June 11th to complete them. For those who are getting the CNE, you'll need to complete the post-session quiz as well. And then we'll be sending out certificates by email by June 17th. I think we have a quick 2 or 3 question pop-up just about today's session. Kelly, do you have the final pop-up? Perfect. Here we go. So take a minute just to go through that. So just looking, as you finish those questions, I'm just pulling up the Q&A. Um, there was a question about rapid tests for measles. I am not aware of any rapid tests. I know that all samples do get sent to the state lab here in Rhode Island, but that's definitely something that I can look into and we can get back to you. Masking is there's a question about how effective masking for patients is at preventing transmission. It's very helpful, right? Because we know how it's transmitted with those uh, respiratory particles. And so by having a patient wear that mask, you are preventing um, those particles from getting into the air. So masking our patients is super helpful as well. Any idea how long after exposure with the World Cup it would be before we might see measles in Rhode Island? So, uh, I mean, potentially quickly, right? We have an incubation period of up to 21 days. And so, depending on how many people come that are currently infectious, right, it's going to be a matter of, how many cases are being brought in. But I think it could happen, in that first potential 21 days, and it will extend beyond that because there's going to be people kind of continually arriving for different games over the period of it. So, depending on what phase of their particular illness they may be in, that will determine, you know, how much exposure they have and also how many people they interact with as well. And then there was a question about surveillance, like wastewater surveillance. Um, I'm not aware of any wastewater surveillance for measles.
I believe we're actually working on it, Dr. Kearney.
Oh, very cool.
So a thing with measles that would be helpful is like for COVID, for example, we are looking at like how much is in the wastewater system. But for measles, we don't want to see any in the wastewater system. So it's a good indication if we see any that we're missing a case. Um, and I did have something to add to your last question. Oh, the World Cup. So even if a case comes to Rhode Island, and we diagnose them here, we would likely keep them here until they're no longer isolating. So it technically wouldn't be a Rhode Island case, but we would have a case of measles and then have to do contact tracing based off of that. So it could be instantly that we have a case if someone comes here ill. Uh,
Yeah,
Knock
and
on wood, really
CDC
hoping we don't.
separates the data into um, visitors from other countries that are coming in and subsequently diagnosed with measles while here versus cases among uh, people who reside here when they report the data. That
I
was
know
it.
we're at time. I also did answer a question in the chat about immunity. So yes, you are considered immune if you can prove your documentation. If a
Mhm.
healthcare worker cannot prove their documentation, which should be collected at time of hire anyways, which is regulation, um, then we do ask that they stay out of work until they can at least get another vaccine or get the vaccines if they don't have one on board or get proof of.
Yeah, awesome. Well, I appreciate all of you for joining today. If there's any more questions that come up, feel free to email us. We are happy to get back to you on it. And I hope this was helpful. You guys are doing some great work, and so we really appreciate everything that you're doing. Um, Enjoy the rest of your week and let us know if we can help. Thanks so much.